If you have ovaries or you care about somebody who has ovaries, you really should listen to this episode. Why? Because today, Dr. Serena Chen will tell us about PCOS, about when to see your doctor, about when to get a fertility workup. And some of the answers are different than what you would think. So if you want to plan for your reproductive life, if you're thinking about your health, if you're thinking about starting your future family, or even in menopause, thinking about how you can take care of yourself, this episode is for you. She will also talk to us about her group called Doctors for Fertility. It's a fantastic group, and they do so much to help our reproductive rights. So tune in. I think you're really going to enjoy this episode. Welcome to Building Your Family. This is a podcast about donor conception, fertility treatment, surrogacy, and all the ways the modern family is built. My name is Lisa Schumann. I'm your host. I'm a therapist, an author, a researcher, and I am so delighted to have you here today because I want to introduce you to one of my very favorite people, Dr. Serena Chen. Dr. Chen is founding director of the Institute for Reproductive Medicine and Science, serves as the director of Division of Reproductive Medicine in the Department of Obstetrics and Gynecology at the Cooperman St. Barnabas Medical Center, and clinical associate professors at Rutgers, and many other things, including many awards like Resolves Hope, which is an amazing award to win. If you're not in this industry, you don't know it is the absolute top award. Jersey's top doctors, New York Magazine's top doctors, Castle Connolly's top doctor, on and on and on and on. She is an amazing, amazing physician. She is an amazing practice leader, and she is an amazing advocate, which we will talk about later because you need to hear all about Doctors for Fertility and why she started it. But first, we want to give you some education about a subject that's really important to learn about, and there's a lot of confusion. So Dr. Chen is going to help us understand it, and that is PCOS. So thank you for joining us, Dr. Chen. So happy to have you here.
So wonderful to be here, Lisa. I'm honored to be on the podcast, and I love talking about women's health, and PCOS is a big topic because it affects almost 1 in 5 women.
Wow.
We're not really sure actually about the number. That's one of the issues, is that we don't have a real test for PCOS. So it's a challenging disease because so many women are out there probably suffering from the symptoms, maybe suspecting that they have PCOS, and yet seeing doctor after doctor after doctor and really not getting any answers or any solutions.
And so how does that evolve? How do people understand if they have PCOS? What are the symptoms? What may they start thinking about? Because people usually just go to their gynecologist every year, have their pap smear, and then they're done. So how would they even begin to think about this?
Anyone who has irregular cycles should be thinking, I might have PCOS. Pregnancy and PCOS are probably the number 1 and 2 causes for irregular cycles. So once you rule out pregnancy with a pregnancy test, you have to say, well, why are my cycles so irregular? Certainly, birth control pills are a really safe and wonderful and effective treatment for a lot of situations that have irregular cycles. But ideally, you want to have a diagnosis and not just treat the symptoms. That's a tough one, I would say. Like I have to say, most women with irregular cycles go to the doctor, and as long as they don't have cancer, as long as they're not pregnant, then usually we're just putting them on birth control pills and not necessarily digging for the answers. The problem with PCOS is that because there's no single test, because it's a woman's disease, and women's diseases have not been researched very much, there's very little funding. Women's diseases comprise a very small portion of federal funding in terms of looking at scientific and medical research. And yet, we're half the population. And PCOS, as we suspect from what we know, affects possibly almost 20% of women. We don't know for sure.
Wow.
And because there's still so much we need to know. So what usually happens is people go, they have these complaints, they have these symptoms. The doctors just make sure there's no big emergency like pregnancy or cancer, and then they're sent out the door with pills, and they may go to doctor after doctor after doctor. A lot of the patients that come to see me have suspected for years that they might have PCOS and yet have been never really been evaluated by a doctor, just put on birth control pills, or have been told, well, I did your blood tests and everything looks fine, so I don't think you have it. And yet they have PCOS. So that's another very common mistake, is that people think you can do a blood test. And there are some common blood tests that we want to do in everybody with PCOS, but they don't necessarily diagnose PCOS. So PCOS is more of a clinical diagnosis. You have to look at the person as a whole, look at their symptoms. Most common symptoms are irregular periods, sometimes acne, hirsutism, excess weight. If you have severe PCOS, you can have skin changes called acanthosis nigricans. So around all your skin folds, darkening of the skin. Those are some of the most common things, and infertility. Those are some of the most common things that bring PCOS patients to the doctor or make them worried and make them think something is going on. But a lot of these people, you can do blood tests and they may come back totally normal on their blood tests. Typically, we're doing FSH, LH, estradiol, and progesterone. And a typical classic PCOS patient will have kind of a lower FSH, a higher LH, and low estrogen and low progesterone because they're not ovulating. So that's called an inverse LH to FSH ratio. And yet, when you look at a lot of the studies, only about half of PCOS patients in studies will have a difference in their LH to FSH ratio. And in the studies, we're not even sure that we're capturing everybody that has PCOS, because we do now think there's a really wide spectrum of PCOS, and there can be some people with very mild manifestations, as well as some people who are classic PCOS, where they fit all the textbook definitions. And then we check androgens very commonly in patients. And a lot of people with hirsutism or acne have elevated androgens by their bioassay, which is their body. Your body is a type of test that often can be much more accurate than blood tests. So if you're growing excess hair, and not just hair anywhere, hirsutism is a particular type of hair. It's called sexual hair because it's part of secondary sex characteristics. So, and it's mediated by the sex hormone. So hair in the mustache and the beard area, on the chest area, in the upper abdomen, those are all, if you have excess hair in those areas, or male pattern balding, those are all signs of excess testosterone at the level of the hair follicle. But if we measure your blood might not demonstrate excess testosterone or excess androgens.
Wow.
So it can be difficult sometimes to figure out if somebody really has PCOS or not. And then you do need to do testing, like you need to check your thyroid, you need to check prolactin level, you need to check adrenal hormones, because you want to make sure that you don't have thyroid disease or adrenal disease or hyperprolactinemia, all of which can look kind of like PCOS, but are not. So PCOS, you need to eliminate other causes for irregular periods or for your symptoms, and then you put together the clinical picture. I think the final piece, besides your history, that's very commonly looked at is ultrasound.
And what do you see there?
So there's a classic PCOS appearance of the ultrasound where you have lots of antral follicles, lots of little tiny follicles, and excess stroma in the middle. So a classic PCOS ovary is kind of round and puffy and has what's called a string of pearls around the edge. Those are all the little follicles, and a chunky middle, that's the stroma. So it's a classic appearance. And yet, interestingly, even though a reproductive endocrinologist like myself, we can put in the vaginal probe and say, oh, that's a PCOS ovary, we don't really see classic radiologists making those kinds of remarks typically on scan. So a patient will go get an ultrasound scan, and it's not really standard to count all the antral follicles. It's not really standard to say, oh, could be consistent with PCOS. That's not a standard part of the reading. So we have all these different parts of the healthcare system not putting together all the pieces for PCOS, except for reproductive endocrinologists like myself, we are, have a lot of training and experience in this area. And yet there's so few of us. And most people who are struggling with PCOS really will only see a gynecologist or their primary care doctor, and may not even have access to a reproductive endocrinologist. And the OBGYN and primary care doctors not only maybe don't have special training in this area, but they also are under tremendous amounts of pressure to just get the patients in and out the door.
Yes, absolutely. So I wanted to ask you about that. But before that, I know people are curious about this. I wanted to know a little bit about the lean PCOS, because sometimes people will go on the internet and say, "Oh, do I have PCOS, Dr. Google?" And then they see all of these things about being overweight and all of that. So what about lean PCOS?
You definitely can have lean PCOS. That's definitely something that exists. We do think PCOS runs in families. We also think PCOS has some genetic basis, maybe some environmental basis, probably multiple genes are involved. We really don't know. A lot of people feel like maybe there's something going on with the insulin receptor, because almost all PCOS patients have elevated insulin resistance. And it's interesting because when you look specifically at lean versus overweight PCOS, anybody who's overweight, even if they don't have PCOS, the excess fat leads to insulin resistance. But when you look at people who are the same weight, one who's overweight and one who's overweight with PCOS, the person with PCOS will have significantly higher insulin resistance. And then if you compare a lean PCOS person to overweight PCOS person, and then compare them to a lean person without PCOS, the lean PCOS patient will have insulin resistance kind of in between, higher than another person of their same weight who doesn't have PCOS. So the insulin resistance from PCOS does appear to be separate from the excess weight. And we can definitely see that's one characteristic of lean PCOS. We can definitely see excess insulin with them. And so even if you have lean PCOS, your risk for things like diabetes and high blood pressure are still increased, and gestational diabetes are still increased compared to somebody who doesn't have PCOS.
So it's a really significant issue for a lot of people. And how will this affect their ability to become pregnant?
A lot of people with PCOS have irregular periods. That's probably the most common symptom that we see. And that causes infertility, because when you have irregular periods, it usually means you're not ovulating. And if you're not releasing eggs, then you're not going to be able to get pregnant. So we really feel like anybody with irregular periods should be evaluated right away for the possibility of PCOS. They shouldn't follow that standard guideline, try for 6 to 12 months to get pregnant. And if you're not pregnant after 6 to 12 months, then you go see the fertility specialist, or then you go get the fertility evaluation. People with irregular periods should be evaluated right away.
So if someone's going to the doctor and they have the regular pap smears and they say, well, here I am 32, 33. I'd like to start my family at some point. I'll try at home for a little while. And if I start having some problems, I'll see a fertility specialist. You're saying people should really get a workup before thinking about it any further if they're having irregular periods.
Yeah, when you have irregular periods, you should probably, and you're trying to get pregnant, you should probably see a fertility specialist right away. Even if you're not trying to get pregnant, you should see a physician about your irregular periods. Irregular periods can, like if you don't get a period for a year, or if you're bleeding too often, that can be a sign of an increased risk for cancer of the lining of the uterus and polyps and overgrowth and things like that. So it's not something that develops right away. So I don't want people panicking that they have to, they don't have to go to the emergency room or anything like that. But it is important. If you have irregular periods, it is important to see your doctor and find out what's causing the irregularity and get it regulated, even if you're not trying to get pregnant, because that irregularity usually means there's too much estrogen, not enough progesterone, you're not ovulating, and that can lead eventually to an increased risk of cancer of the lining of the uterus.
That is so important because in my experience, very often people just go to their gynecologist. The gynecologist says, well, maybe you had a stressful month or maybe something else is going on. You lost some weight, you gained some weight, you missed a period, no big deal. I'll put you on birth control and you'll be fine.
The good news about birth control pill is it dramatically reduces your risk of endometrial cancer. So that birth control pills can actually be a great medicine for
Oh,
people with PCOS. It can treat a lot of things. So it can prevent cancer of the lining of the uterus. It actually dramatically reduces the risk for ovarian cancer.
wow.
PCOS patients might be at slightly increased risk for ovarian cancer, not hugely increased risk, but it does reduce the risk for ovarian cancer for everybody that takes birth control pills. It can also reduce growth of fibroids. It can also help with the hormonal profile. So it can lower testosterone levels, raise sex hormone binding globulin levels. That lowers free testosterone levels, and that really helps with acne and hair growth and those kinds of things. So birth control pills actually are a really great tool to help with treating so many symptoms that you see with PCOS. Now, a lot of people worry about birth control pills because
Yes.
everyone thinks, oh my gosh, I'm going to gain weight on birth control pills. First of all, you should be on the lowest possible dose that will control your symptoms. There are super low dose pills available now, a huge wide range. So you should start on something very low dose. Second of all, hormones don't actually make you gain weight. Sometimes they can make you gain maybe 1 or 2 pounds of water weight, but more than that, something else is going on. What's going on
Oh,
is that often birth control pills can be a little bit of an appetite stimulant. And
mm,
if you go down that carbohydrate rabbit hole, then you just listen, to your gut and don't keep track of your calories, then it will seem like the birth control pills are causing you to gain weight. But what's really happening is the birth control pills may be impacting your appetite, and then you're eating more, and that's why you're gaining weight.
uh-huh.
So I tell people what you need to do is, if you're forewarned about it and you know what's happening, then you're empowered. You can do something about it, and you can make sure you have plenty of high quality, high protein, healthy fat snacks like, you know,
That's
nuts. I think low salt almonds, like they come in those little 100-calorie
mm-hmm.
packs. You can keep them in your pocket next time you have some hunger pangs. Instead of having a donut, you have like a few
Yes.
calories of nuts, and you're getting some nutrition and some protein and taking care of the hunger pangs. And then you're not gaining weight on the birth control pills. Not everybody has this appetite stimulation, but it is definitely something you want to look out for.
That's so interesting. And, it seems like for so long people were worried about being on birth control pills because they thought it would increase their cancer risk.
Yeah, and they actually lower cancer risk in a lot of ways. People were concerned about breast cancer, and
Yes.
from what we've seen, there are a couple studies saying there might be a slightly increased risk of breast cancer, but the vast majority of studies do not demonstrate an increased risk of breast cancer. And for most people, the vast majority of people, the benefits of the birth control pills far outweigh any risks.
That's amazing. That's so helpful. My name is Lisa Schumann. I'm a therapist, a researcher, an author, and I am passionate about helping people find a better journey to parenthood. I created the Center for Family Building to help people understand how to make decisions not just for the short term, but for a lifetime. We have group counseling, individual counseling, couples counseling, and lots of other services that can help people find the answers that they're looking for. Just take a look at our website so you can see a few of the thousands of people we helped build a better path to parenthood. The decisions you make are too important to leave up to chance. Arm yourself with the right information. Take a look at our website and sign up for a session with one of our therapists, join one of our groups, or access one of our programs, and you will quickly see why our strategies are so effective. Now back to our episode. So you're saying that if people are thinking, I want to get pregnant, I want to start my family, I may have some of these symptoms, check it out. Go to a fertility specialist because your gynecologist may not know or may not have the time to really fully explore it. And you really have to be your own advocate here. It's so important to really think about that.
Yeah, especially these days with our healthcare system, like since COVID, we're seeing such a shortage of doctors and nurses and the
Mm.
healthcare system really being strained. And as we talked about earlier, the lack of resources put towards women's health, research, and knowledge. I do think advocating for yourself is really, really important. And I do think there can be, I always joke about Dr. Google. Dr. Google is the number one doctor in the world
Yes.
because people see 10 Dr. Googles before they see, a real doctor. But Dr. Google didn't go to medical school, so you can
Mhm.
really get into trouble. But there are a lot of good sources of information out there, like the American Society for Reproductive Medicine puts out a lot of patient information. Organizations like the March of Dimes, American College of OBGYN, the CDC, the WHO, there are really good sources of good vetted information that's accurate. You can't follow just anybody, online because there are a lot of people calling themselves doctors and they're not actually physicians. And there is a lot of crazy stuff out there. But if you start with some of these sources that are established, then I think you can get some good information, and you want to make sure you ask plenty of questions. And, if you're not getting the answers and your doctor is not really listening, then it may be time for another opinion.
And it's so important, going back to what you were saying before, to see a reproductive endocrinologist because just like you wouldn't have your teeth cleaned by an ophthalmologist, why would you just see, anyone to deal with PCOS? You need to really see someone who can accurately diagnose it.
Absolutely. And I think people need to know also beyond the reproductive lifespan, we think that PCOS impacts you through your entire lifespan. So even as you get older, a lot
Hmm.
of people who have PCOS and irregular periods when they're younger will become more regular. But all those things, the insulin resistance hasn't gone away, and they are still at increased risk for high blood pressure, high cholesterol, heart disease, diabetes. That'll go through menopause. And that's something that really people have not been paying attention to. And I think as women, we really have to look out for ourselves and make sure, like we get evaluated.
And so, what would the treatment then be if someone comes to you and you say, "Yes, I see you have PCOS"? What's the typical treatment that someone can expect?
The most common treatment is ovulation induction with a fertility pill. Right now, most people in the United States are using letrozole to induce ovulation. It used to be for many years Clomid. Clomid is still a great drug, but some more recent studies have shown that the multiple pregnancy rate is a little bit lower with letrozole. That's become kind of the number one go-to. So letrozole is a medication that actually was developed to treat hormone-sensitive cancers. So
Mm.
it's an aromatase inhibitor, and aromatase is the enzyme that makes testosterone into estrogen. So if you stop your body from making estrogen, then your estrogen levels drop. And PCOS patients tend to be stuck in this cycle where instead of cycling around the menstrual cycle, they're stuck where the estrogen level is here, the FSH is here, and they can't get to a point where their body starts to recruit a follicle and ovulate. And if we drop the estrogen, then it helps boost the FSH. The FSH then stimulates the ovary and can start the development of a follicle and induce ovulation. And what we're
Mm.
aiming for is just to get like normal ovulation, to just have one follicle ovulate at a time. So that's one of the most common treatments, is that we induce ovulation with letrozole. Sometimes we'll add a shot, sometimes we'll add intrauterine insemination, but basically, if that's all that's going on, that you're not ovulating, then a lot of people will have great success with letrozole. A lot of people ask, can I do something more natural? Sometimes just taking a supplement like inositol can be helpful. Inositol is a
Mm.
small carbohydrate. Typically, what we're giving is a combination of myo-inositol and D-chiroinositol, your body makes these carbohydrates anyway. And apparently inositols are the second messenger for the insulin receptor. So when insulin binds to the receptor, inositol is released into the cell and it carries out it sends out the message of all the actions that insulin is supposed to take inside the cell. And so inositol, if you take it, and it's usually like a powder or a capsule you take twice a day, it actually acts like WD-40 for the insulin receptor.
Oh, wow.
So it seems to lower insulin resistance just by helping the insulin receptor to work more efficiently. So if you lower insulin resistance, then that will help some people to ovulate. It's not nearly as reliable as the letrozole, but it's an over-the-counter supplement that I think can be helpful, especially if people are kind of almost ovulating. Like if they have mild PCOS, maybe their cycles are like 35 to 40 days instead of 28 days. And something like inositol can be helpful. We also use I use inositol a lot for all my PCOS patients because it does help lower sugar levels. It can reduce the risk for gestational diabetes.
Wow.
I think if you can lower insulin levels, it can be part of a healthy weight loss program. It can be very supportive of that, because if you lower insulin levels, then your body's metabolism is a little bit better. And using inositol and, of course, eating lots of veggies and getting good sleep and getting exercise can also be helpful. Building muscle can lower insulin. So there are multiple different ways to lower insulin levels. If you can lower insulin levels and lower insulin resistance, you can make your metabolism a little bit more normal, because PCOS patients, a lot of them have excess weight, not because they're eating badly, but because of their metabolism.
That brings me to another question, because you probably also see on social media and all of these places that there are people who say, well, you can take the supplement, or you can change your diet, or cut down on your carbs, or have a high protein diet, all these ideas that you can use. And meanwhile, people try them. And then before they know it, they're 35, 37, 38. And they're kind of missing out on these really crucial years.
Yes.
That must be very difficult for you to watch.
Yes, Lisa, that is a really good point. We're seeing a dramatic decrease in the birth rate, right? In the United States and other developed nations, we're not replacing ourselves. People are waiting longer and longer to have families. And it is a real concern, because that is the number one cause for infertility in the United States, is just advancing age in both men and women. That biological clock is not a myth. It's very, very real. And it has a powerful impact, especially on female fertility, so that we can see measurable declines in your fertility every single year, starting around age 30. Now,
Yes.
I don't think people should panic about that, but I do think people should be proactive and think about family planning. And, you can't have a baby until you're ready. And that's why it's nice that egg freezing is maybe an option. It's definitely something. It's not as accessible as it should be. It really should be covered by insurance. And most of the time it is not covered by insurance. That's one of my dreams. I hope we can help, bring that kind of access to people. I think, if all the great minds of the world are worried about this declining birth rate, that's something that people should be pushing for, is universal access to egg freezing. Definitely, people should be thinking about the biological clock. They should be talking with their doctor or fertility specialist about ways to address that, like egg freezing, but also simple things like quitting smoking and cutting back on alcohol and getting healthy. That those kinds of things can be helpful as well to your ovarian health. You're right. People shouldn't delay. They should. Just because you're seeing the doctor doesn't mean you have to do anything you don't want to do. It can just be getting informed about your health and your options and ways to, optimize your reproductive health.
That's so important because so many people really say, well, I'm very emotional about this. I wanted to try the natural way first. And we don't realize that we're losing our ability with every month, every year to get pregnant. And so it makes so much sense to first see the fertility specialist and then see if there's a quick fix, if there's some medication you can take or not. Maybe it's more dire and you have to get on it, but maybe then you have a little time to try the natural way. But first, check it out.
I'm seeing more people being proactive, like just coming in and saying, listen, I don't necessarily want any fertility treatment, but I just, we just got married, or, we're going to think about having a baby next year or someday. And we just want to make sure that everything looks okay. And there's nothing, nothing wrong or any big risk factors. And I think that's wonderful that people are doing that. Certainly not coming from the healthcare system. We don't really have a healthcare system. We actually have a disease care system. Yes. And I do think we're trying to become more of a healthcare system, but we're really not proactive. So I do think that the burden of being proactive about your health is really, most of it is on the patient to say, Doc, I'm not here because, I have a problem. I'm here because I want to be as healthy as I can be.
Yes. So speaking of which, I thought maybe you could talk a little bit about the healthcare system and your enormous efforts to try to make a change in the healthcare system. You founded Doctors for Fertility you could talk about some other physicians that you brought on board to help you out, but it's an amazing endeavor. And it's so great that you're doing this, Dr. Chen.
Thank you so much, Lisa. So it's been crazy. In May of 2022, Natalie Crawford, who's a fertility specialist in Austin, Texas, called me up and said, that's when the Dobbs decision was leaked. And she called me up and said, Serena, I'm really concerned. This is going to affect IVF. It's going to affect reproductive health care. I think we should talk about it. I think we should do something. And she got together with me and Laura Shaheen, a fertility specialist in Seattle, Dr. Ruhi Jalani, fertility specialist in Chicago, Dr. Lucky Sakhan in New York, and Dr. Stephanie Gustin in Nebraska. The group of us then put our heads together and started Doctors for Fertility, a not-for-profit. And we actually have two parts to the organization. We have a C3 for raising awareness and education and advocacy. And then we also have a PAC, a political action committee, that's really gearing up right now that it's an election year to try to get people elected who will protect reproductive health care. And we realized when we started, because we talked to a lot of people, we realized that there were no political action committees that were actually specifically protecting IVF. A lot of people think the overturn of Roe v. Wade is just about abortion. And a lot of people think of abortion as elective termination of a viable unwanted pregnancy. But I think now people understand that abortion covers all of complicated pregnancy care. So you may have a very desired pregnancy and not want to end the pregnancy and yet have to because of medical reasons. But we're not just talking about reproductive health care. We're also talking about IVF, because the way a lot of these laws try to regulate termination of pregnancies is they give a legal status to a pregnancy before it becomes a person. And these laws are called personhood bills. So the principle of personhood is how we approach legislation post-Dobbs when it comes to trying to control abortion. So what the politicians are saying, well, this embryo or this pregnancy or this fetus actually has the same rights as a person, the same rights as you or I. And therefore, because it has those rights, you cannot have an abortion. So that's how a lot of these laws work. The problem is that it sends the law into a crash course with the healthcare system, because it completely disrupts the way we treat patients in general. So it's saying that doctors can't do things unless the person, and sometimes there's no exception actually for risk of death. But most of the time, a lot of these laws say you can do an abortion if we know, provable in a court of law beyond a reasonable doubt that this person would die without this procedure. And of course, doctors don't know when somebody's going to die. We don't make any of our decisions this way. All of our decision making is based upon risk and benefit, and also patient healthcare and bodily autonomy. So you put together the risks and the benefits, the doctor and the patient talk, and ultimately the patient and the doctor decide together what is the best thing to do. And these laws have actually legislated malpractice, and because they're telling doctors to do exactly the opposite of what we've been trained to do. If you treated somebody with appendicitis this way, and you were worried about going to jail unless you let the appendix rupture and let the patient almost die before you took out the appendix, that would be malpractice. And that is essentially what we're being told to do by these laws.
Yes.
So we realized, as six IVF doctors, that we had a very strong message to put out there, because we know that even people who are against elective termination of pregnancy, even people who are very religious, even people who are very, very right-wing Republican, they all have IVF babies in their families. Everybody.
Yes.
Infertility impacts everyone. And we know that maybe up to 1 in 5, up to 1 in 6 people are impacted by the difficulty getting pregnant and need help getting pregnant. And so we knew that we could have a chance by speaking up as fertility doctors against these laws. We had a chance to reach across the aisle, because we could show people this other side, that people who are trying to have families, people who are struggling with infertility, how these laws affected their healthcare. That's our hope, is to be able to get people to understand that these laws affect all of healthcare. They affect IVF, they affect abortion care, they affect pregnancy care, and there are ripple effects for care for men and children as well. So it really impacts the entire healthcare system, because it's contributing to doctor shortages, it's impacting physician training, it's impacting who's going to medical school and where they're going to medical school, where they're training. So it's really straining an already extremely strained healthcare system post-COVID.
Yes.
So the 6 of us got together, and we started Doctors for Fertility. We have a wonderful board, advisory board as well, reproductive endocrinologists and maternal fetal medicine specialists, even a radiologist from all across the country. So we'd love for people to, follow us on social media and think about donating, sign up for the newsletters. The C3 is very education and advocacy based. And our mission is not just to address the impact of DOMS, but it's also to address the lack of access to fertility care in the United States. We are one of the worst nations in the developed world when it comes to access to IVF, that the vast majority of people in the United States who need IVF, who have a medical indication for IVF, don't have insurance coverage, even if they have good commercial insurance. It's kind of crazy that without insurance mandates, insurance companies are just like, no, we're not covering that disease. Sorry. It's crazy. So our mission ultimately is not only to keep IVF legal and to keep pregnancy care legal and safe post-DOMS. Our objective is to make sure ultimately that everybody who needs IVF, whether it's for egg freezing or for infertility or for genetic disease or whatever, that everybody who needs it has access to it.
Yeah. So you raised some important points that I think people are not really thinking about as much, that there are genetic diseases that people can have. It's not just about saying, well, I feel like postponing my pregnancy so I can boost my career. It's people have all sorts of reasons for wanting to pursue fertility treatment. There are medical issues. There's all sorts of problems, as you mentioned, in pregnancy, tubal pregnancies, all sorts of things like that, that could require somebody to have a termination. But also, I think people are also confused right now about pursuing fertility treatment, about if I'm in a certain state, am I safe? Where do I put my embryos? How do I know my embryos are going to be safe? What do you say to those people who are watching and thinking about all of these things that are making them feel nervous now?
So I'd say right now, IVF is legal in all 50 states. The Alabama situation is tenuous. Alabama was shut down for a little while because it was illegal to do IVF in Alabama because the Supreme Court ruled that frozen embryos could be considered having the same rights as minor children. So the accidental destruction of frozen embryos in Alabama was considered like a manslaughter case instead of just a tragic accident. The situation in Alabama is IVF has moved on, but it is a tenuous situation because personhood is still the law of the land in Alabama. And so it's a very uncertain, tenuous situation where we're kind of walking on eggshells, just waiting for the other shoe to drop. And of course, once you're pregnant in Alabama, that is one of the strictest states in the nation in terms of abortion care. So any pregnancy complications really can put your life at risk because it's not clear that standard pregnancy care for complications is legal. It's most of it is illegal in Alabama. So it's still a very, very difficult situation. So I don't think people should panic. I think people should definitely seek care, seek information, and get all the advice they can, and then together with their doctor, make these decisions. We are seeing that, it's definitely illegal to discard embryos in Louisiana and probably in a lot of other states. So that's at question. But right now, doing IVF and conceiving via IVF is not illegal. We are concerned about the frozen embryos. We are seeing that some people are concerned enough to move their embryos. I don't know that right now people need to move their embryos. They should talk with their doctor first, but we are seeing some trends like that. I do think that even though I don't want people to panic, I don't want people to opt out either. This is a very concerning situation. And we are seeing dramatic increases in maternal death rates and complications directly because of these laws since Dobbs has been passed. And we have seen papers published on this. So it really is having an impact. So you do have to take that part seriously. You do, if you live in a state where pregnancy care is maybe illegal, where it just, hopefully you never have a complication and it doesn't impact you, but you should talk with your doctor about that. And you should think about, like, what would be the backup plan if something like that happened?
Yes.
Where could you go? Like, I have a patient who found, after 2 years of looking, a wonderful carrier, and the carrier's in Indiana. And we at first really panicked about that because Indiana has very strict abortion laws. And we worried, like, what if the carrier gets an ectopic, or what if she has a miscarriage? Where is she going to get medical care? Luckily, that carrier lives 15 minutes away from the Illinois border, and her doctor actually is in Illinois. So that, that's one example of a backup plan. And I know that's not accessible to everyone, but if that's a possibility for you, we really want you to think about that. You need to talk to people about it. You need to talk to your legislators about your concerns about your health and your healthcare system. It is important to let your representatives know, regardless of what party you are in. We have seen, like in Nebraska, Dr. Gustin and Dr. Abby Delaney are both Doctors for Fertility board members, and they were able to shut down one of the strictest laws in their state. They were going to have, right after Dobbs, a complete abortion ban, and IVF was going to be struck down. And then they also struck down a 6-week abortion ban. And they convinced one of the Republican legislators, just by talking with him, like getting together constituents and talking with them about their concerns about healthcare. So I do think it does seem like things are super, super partisan and super divided. But like I said, I think becoming a member of Doctors for Fertility and putting on the Doctors for Fertility hat and saying, this is about families. This is about making families and having healthy pregnancies. Let's just have a conversation about healthcare. You can make a difference. And it's a good way to have a conversation without it becoming a yelling match. I mean, obviously there are some super extreme people, but there's a lot of data out there that regardless of party, regardless of religious affiliation, the majority of Americans really believe in healthcare and understand that Dobbs has a negative impact on healthcare. So even if they're against abortion, most Americans are for abortion.
The right to choose.
Just because it means safe healthcare. So, I'd love to we would love to come talk to people's groups about this, like to do the Doctors for Fertility advocacy training so everybody feels comfortable talking about this, to a friend or a family member or to their legislator, because all of our voices really make a difference. And of course, we want you to vote. We want you to encourage other people to vote. And we would love for you guys to consider donating to the PAC, because we are going to be donating to candidates specifically to try to protect reproductive health care and access to IVF.
And that's, more important now than ever, because we're obviously going to air this episode before our election. And we know that we've heard a lot of things, online about pregnancies being aborted after the baby's born and all of this stuff.
I know, that's why do they talk about these things that don't exist? If the baby's viable, then that's called a delivery.
Yes, exactly. Right.
That's a delivery. That is not an abortion.
Yes.
We are not doing that.
Yeah, it's pretty remarkable that this stuff gets aired. There are lots of negative voices out there that are very loud, and it's hard to counteract them. But for everybody out there, please listen to Dr. Chen, because it's so important to get good information out there about fertility care, about the access to abortion if that's right for you. And if it's not right for you, that's fine, but at least it should be an option. You don't want to close it off as an option to people. And certainly for all the things that we're talking about, PCOS and advanced maternal age, all of these things, even if they are subjects that are hard to think about, they are so important to think about and to get the right information from your doctor. And Dr. Chen is a great source of information. And Doctors for Fertility, I encourage you to join them. And where can people find you, Dr. Chen? Where can people get in touch with you?
You can find me on Instagram at Dr. Serena H Chen. You can also find us at Doctors for Fertility on Instagram, and DFF_PAC, PAC, on Instagram and on the web. So hopefully you'll put the links in the show notes, Lisa.
We will absolutely.
Yeah. And so,
Yes.
We want everybody to sign up for the newsletter. The newsletter is really good. We're just trying to keep everybody updated on what's going on with reproductive access and IVF access. On social media, we will be asking people to lend their support to things like the ballot measures and keep you up to date. Right now, our big focus is there are about 16 states where we feel like IVF access is most at risk. And we'll be working together with Resolve and ASRM and Fertility Within Reach and the Cade Foundation and other organizations to all, try to protect access, especially in those states at risk.
That's so wonderful. We are so lucky to have you, Dr. Chen. I'm so appreciative for everything you're doing. You're so busy, and you're doing all of this to really help our country, because these things are, as we can see, they feel irreversible, but with some support, there can be movement. And it's so important to appreciate that. I know a lot of people feel deflated from everything that's happened, and it's understandable, but please shore up your support for Dr. Chen and her team, because they are out there.
Lisa, I just want to say, you can look at places like Kansas, where the right to abortion was protected. The constitutional right to abortion was protected by a huge bipartisan margin, because the people that were trying to support this measure really talked about healthcare. And Kansas is a very, very Republican state, but
Yes.
They got bipartisan support for that. So we know that if people speak up and they get involved and they get educated and aware and they vote, we know we can make a difference. Texas is a really tough one. We're fighting in Texas, but we just also got egg freezing for cancer patients covered in Texas. So
Wonderful.
I know it sounds awful out there and it sounds hopeless, but it's it's definitely going to be a lot of work, but it's definitely not hopeless.
We have to keep at it. And we have such a wonderful, wonderful group of people who are on the right side of the aisle doing the right things and helping. And I'm so grateful, Dr. Chen. Thank you so much for all you do. It's really so fantastic. And thank you all for listening. This is a really, really important episode. I hope that you took notes and that you are listening and that you donate to Doctors for Fertility, and certainly reach out to Dr. Chen with questions. She's a lovely person and a lovely source of information. So please do that, and certainly subscribe, because we need you to come back and be informed about all of these things that will affect all of us. And thank you for listening again, and I will see you next week. Hi, it's Lisa Schumann. I hope that you enjoyed that video, and I hope it helped you. And if it did, please give us a thumbs up and subscribe, because that's how we keep going. It's really important to us. And if you liked it, you might like this one.